Hello, thank you so much for the invitation to speak about the thyroid nodules and cancer in children and adolescents. My name is Hanneke Van Santen. I'm a pediatric endocrinologist working in Utrecht in the Netherlands. And the learning points of my talk today will be to talk about the relevance of centralization of care for pediatric thyroid cancer, how to distinguish a benign thyroid nodule from thyroid cancer, what is the current European approach to pediatric thyroid cancer? And what are the points of attention in follow-up of the child after treatment for pediatric thyroid cancer? So first, I will address the relevance of centralization of care. So just a little bit about my background. So this is my hospital in Holland. It's the academic pediatric hospital. And in 2018, a new hospital was built beside our academic hospital, which is the new Pediatric Center for Pediatric Oncology. And because all children in Holland with cancer are now treated in this hospital, a big discussion arose whether children with thyroid cancer should also go to this hospital, because pediatric thyroid cancer was an endocrine disease and not an oncological disease. So this started the discussion whether pediatric thyroid cancer should be centralized or not. And it also started the discussion whether thyroid nodules should be seen in a specialized center or not. And why? Because a thyroid nodule may be indicative of thyroid cancer. And this is, of course, a rare disease in childhood. So if we have a child with a thyroid nodule, where should this be done? Should this already be done in an expert center? And who should do the workup for a thyroid nodule? And is a thyroid nodule, thyroid cancer, an endocrine disease or an oncological disease? And in my work across Europe, I found out that this is very different amongst the countries. And this may also be different in the Arab countries. And for Holland, we now made a scheme for the levels of the providers. So we made 4 levels of care, level 1 being the general practitioner, level 2 being the pediatrician, level 3 being the pediatric endocrinologist, and level 4 being the thyroid expert team. And in every level of care, the child with a lump in the neck or with thyroid cancer can enter, but the treatment for thyroid cancer should be done in a level 4 expert center. And what's a level 4 expert center? This is a center that has expertise in pediatric thyroid cancer and has a multidisciplinary team, including a pediatric endocrinologist, radiologist, nuclear physician, adult endocrinologist, an endocrine surgeon that performs at least 30 thyroid surgeries per year, a pediatric surgeon, a pediatric oncologist, a pathologist, a geneticist, and a psychologist. And in case there's a nerve recurrence injury, you need the ICU to be present for just in case. So why this regulation of care? And that's mainly because of its prevalence and its rareness. And it's very important to have an expert team for the experience and the interpretation of the diagnostics. And I will show you several patients to illustrate the differences. But first, a little bit about thyroid nodules. So palpable thyroid nodules in children are very rare. And when you perform an ultrasound, you can find them in about 0.2 to 5% of children. And this prevalence increases with age to about 13% in adolescents. And the evaluation of a thyroid nodule begins by determining the risk that it is a cancer. And this already is a first difference in adults versus children. Whereas in children, the risk that a solid palpable nodule is malignant is much higher than in an adult. So when you see a child with a thyroid nodule, the first question is it a thyroid nodule? Is it perhaps thyroiditis? Is the thyroid cyst? Is it a goiter? Is it parathyroid adenoma? Or is it even a lymphoma? And if there's a lymphadenopathy in children, it could as well be a viral infection, or it could be cervical metastasis. So this requires an experienced pediatric thyroid radiologist. And just to show you some examples. So this is one of my patients. He was a boy of 11 years old, no complaints, and mom detected a lump in the neck. And an ultrasound elsewhere showed a thyroid nodule of 9 millimeters. And they were counseled about the risk for thyroid cancer. Parents were severely distressed. And when they entered my clinic, we repeated the ultrasound, and we did not find any thyroid nodule at all, just some small cysts with a normal thyroid function. So we could completely reassure these parents and patients, and the boy has been followed up. Second example of a girl of 13 years old, who also came with a thyroid nodule palpable. Nothing strange at physical examination except a cafe au lait spot on her body. The thyroid ultrasound confirmed the thyroid nodule in this case, but also a thyroid toxicosis, so an increased VT4 concentration. 123 iodine scans showed a hot nodule. And in this girl, a punction was done and the FNA showed hyperplasia. And in the DNA, we found an activating mutation of the gene S, which confirms the diagnosis of McCune-Albright syndrome. Third example is a girl of 16 years of age who also presented with a lump in the neck. And her mom said, well, yeah, since she was a baby, she had these bite lumps on the lips. She was euthyroid, and indeed the thyroid ultrasound confirmed a large mass in the left lobe with lymph node enlargement. We could see the bite lumps on the lips and on the tongue, which were not bite lumps, of course. And on ultrasound, we found this large mass. Calcitonin was very much increased, and we could find metastasized medullary thyroid carcinoma. And this young female had the MEN2B syndrome. Fourth example, girl of 16 years old, normal thyroid function, increased anti-TPO bodies. And because of the anti-TPO bodies, somebody decided to do an ultrasound of the thyroid to see if it's enlarged. By chance, a thyroid nodule was found of 1.3 centimeters with microcalcifications in the left lobe and multiple pathological lymph nodes on the level 3 and 4 on the left side. An FNA cytology punction was done, and Bethesda 5 was found, and this was a papillary thyroid cancer. So these are 4 cases ranging from no disease to severe metastasized cancer, again illustrating the importance of having a good radiologist and an expert team. Now, for children, until 2 years ago, there were no European guidelines. There were the American guidelines, of course, the ATA, and there were some opinion papers, but we needed a new European guideline. And why do we need a separate guideline for children? Because thyroid cancer and thyroid nodules in a child is very different than in an adult. So thyroid nodules are much more uncommon in children than in adults. And when the nodule is found in a child, it has a greater risk for malignancy. And much more often, a genetic predisposition syndrome, or the nodule can be due to having cancer as a child. It's more often seen than in adults. For thyroid cancer, it's more often metastasized than adults. Despite this more often metastasized form, it has an excellent prognosis. Now, that is because radioactive iodine is taken up very well in pediatric DTC. We see a continued clinical response after radioactive iodine with thyroglobulin decreasing in the years after. And of course, it's important to realize that a child has a longer lifespan than an adult. So delayed effects of given therapy are more important for a child than for an adult. And there are almost no prospective studies of childhood DTC, making recommendations super complicated. There are also differences in the genetics between adults and children thyroid cancer. So for adult PTCs, the most frequent genetic alteration are mutually exclusive point mutation in BRAF or in the RAS family. However, in pediatric PTC, fusion oncogenes involving chromosomal translocations in tyrosine kinase receptors, most commonly RET or NTRK, are the most common genetic alteration observed. So not only behavior, but also the genetics are different between the adult and the childhood PTCs. So how do we distinguish a benign thyroid nodule from thyroid cancer? So this is the work of a large group of international colleagues, and you can find this in our publication in the European Thyroid Journal. So of course it's a diagnostic dilemma, and the prevalence of a thyroid nodule described in literature is very much dependent on the cohort that's described. For example, there's a Boston 2013 paper who described a malignancy rate of 21% in palpable thyroid nodules. But the Japan cohort of 2015 described a much lower malignancy rate of 2%. But this is because this was population screening. So it's a completely different population with a different prevalence rates. Now, if we look at the ultrasound characteristics, you can have some specific ultrasound characteristic which makes the chance of a nodule to be malignant more or less likely. And the best way to do is to combine these features. So hypoechogenicity, calcification, taller than white, irregular margin, and increased vascularization. And by combining all these characteristics, you can already define if the nodule is perhaps more likely malignant. And this is the diagnostic flowchart you can find in our paper, which we now use to make the chance for a nodule, to assess the risk of a nodule to be malignant or not. If the ultrasound is suspicious, then we go on to cytology. Before we go to cytology, the radiologist scores the risk of the nodule to be malignant and uses the TRADS system for this. Important to realize that for the adult TRADS, size is taken into account. And this should not be taken into account in the pediatric patients. And on the TRADS, what's missing is the assessment for central and lateral lymph node disease. So this is something that should be assessed. After the radiology, the next step is to perform the cytology, and for this we use the Bethesda system comparable to the adult population. And in the future, next to the ultrasound and cytology, we may add our molecular characteristics and perhaps even the artificial intelligence, which was very nicely described in this paper. So then if the child has been diagnosed with thyroid cancer, what should we do? Again, this is the work of the European Working Group for Thyroid Cancer on pediatric age. And we have recommended that all children should, of course, be given surgery. And we do recommend that thyroidectomy should be performed in all with a lateral lymph node dissection, but we did not advise a prophylactic central lymph node dissection. After thyroidectomy, treatment should be given with radioactive iodine, after which we give TSH suppressive therapy with thyroid hormone. Now, new systemic treatments are upcoming. And for this, we do require a pediatric oncologist also to join our team because it's very important that the treatment is holistic from an oncologic, endocrine, nuclear medicine, and surgical point of view. Now, survival of thyroid cancer is excellent. However, many late effects can be present, especially hypoparathyroidism and recurrent nerve injury, which is something to be aware of. For this reason, we did not recommend a prophylactic central neck dissection. And that's different from the American recommendation because we feel that giving all children a prophylactic central neck dissection will increase your late effects, mainly the hypoparathyroidism and recurrent nerve injury. After the surgery, radioactive iodine treatment is indicated for all children, and we suggest that the dosing should be discussed in the multidisciplinary team. After the radioactive iodine, it's recommended that a second radioactive iodine should only be given minimally after the period of 1 year, because you can see in the year following radioactive iodine treatment that thyroglobulin concentrations still go down. So what about systemic treatments? So these are upcoming, perhaps also for the children, but currently these are not yet indicated in the treatment for pediatric thyroid cancer. There are some case reports about larotrectinib, especially for the NTRK and RET fusion, pediatric thyroid cancers. And I think this is still very experimental. It should only be given in consultation with expert teams in children who have recurrent or non-responsive thyroid cancer, which is extremely rare. So I think we should develop a consensus on the experimental therapy, and the majority of pediatric patients will never need systemic therapy. So if you consider it, could be considered are tyrosine kinase inhibitors or oncogene-specific targeted therapy. But we have many questions. So what's the definition of the response to this therapy? How long should you give this therapy? Can you stop systemic therapy? And should you first consider a radioactive iodine or start with systemic therapy? So I think there are still many questions to be answered. Yes, so what are the points of attention in the follow-up? So after the treatment of thyroid cancer, children should receive TSH suppression until full clinical remission. And after clinical remission has been obtained, TSH can be elevated a little bit to 0.51 milliunits per liter. Measurements of TSH and free T4 should be done every 6 months during growth and puberty, and after puberty once a year. Thyroglobulin should be measured every 6 months the first 3 years, and then this can be lowered to annually. And if there are thyroglobulin antibodies, this can be used as an alternative marker. The neck ultrasound we recommended to do yearly, the first 5 years, or when TG is rising or the antibodies are rising. And again, a flowchart you can find in our publication in the European Thyroid Journal. So one thing about the ultrasound, so one of my students went to Canada to perform a joint study with Dr. Wasserman, and she found that undetectable thyroglobulin was associated with non-structural recurrence. So when the thyroglobulin was negative, no ultrasound finding was found. This means that after the first ultrasound and follow-up, you can follow the patients by thyroglobulin measurements, and we can refrain from ultrasound in the follow-up as standard of care, especially in children who have more often lymph node enlargement due to viral infection. Finding a lymph node can be very worrying for the family. Well, if thyroglobulin is still low, you would wait and follow the lymph node anyway. So we recommend mainly to follow the thyroglobulin and the thyroglobulin antibodies. So the late effects that should be monitored are, of course, the hypoparathyroidism, voice problems, salivary gland dysfunction, possibly cardiac dysfunction. We found no adverse effects on fertility, perhaps for the males. So the boys who already entered puberty, we do advise a semen preservation. We found no adverse effects on bone mineral density, and luckily survivors seem to have a normal quality of life. We recommend a follow-up for at least 10 years, and thereafter, together with the patient with shared decision-making, you can decide where the patient should be followed. So how to proceed for these rare diseases? So in Europe, we've now started a joint registry to combine all our expertise and our patient numbers. And with this registry, we hope that we can have future larger cohorts to perform joint research on, so that we do have the future prospective trials and cohorts that we need to further improve our recommendations. So I hope that I have given you some insight on the European approach to pediatric thyroid nodules and pediatric thyroid cancer. Collaboration is truly essential because it's such a rare disease. For instance, in Holland, we just see around 10 patients per year with pediatric thyroid cancer. So we need to combine our cohorts within Europe, but I hope in the future we can also collaborate with countries outside of Europe. Thank you so much for the invitation, and I'm welcome to any questions.